Our next speaker this morning, who will talk to us on innovations in treatment, is Scientia Professor Richard Bryant. Professor Bryant has researched the nature, course and treatment of post-traumatic for over 20 years. His traumatic stress clinic is recognised as one of the world's leading post-traumatic stress treatment research centres, including conducting the world's first large-scale trial of psychological treatment of emergency responders. Professor Bryant has produced over 500 publications on trauma, stress and anxiety, and has written the seminal book on the acute stress disorder. He has served on both the DSM-5 and CD11 workgroups that have written the recent PTSD diagnostic guidelines. In 2016, he was awarded the Companion of Order in the Order of Australia for services to research and management of traumatic stress. Ladies and gentlemen, please welcome Professor Richard Bryant.
Thanks. Good morning, everybody. I'm going to do something I haven't done in over 20 years, and that is give a talk without my PowerPoints. Now, the reason I'm doing this is really embarrassing, but it sort of maintains the persona of the absent-minded professor. I've literally just flown in from London and managed to hop onto my Qantas flight and leave my laptop in the Qantas Club. So as I stand here, my laptop and its presentation are winging its way to Australia, which leaves me in a rather vulnerable position of being here with no PowerPoints and a dim memory of what I was going to talk about. So, I've been asked to talk about innovations in treatment. And I thought I would talk about it from a very narrow perspective, and I thought it might be relevant to the particular audience here at the Stand Tall Forum. And that is treatment of emergency responders. Now, as we've mainly been focusing on military and veteran populations, it is just worth remembering that emergency responders, and by that I mean police, firefighters and paramedics mainly, they are very repeatedly exposed to trauma, whereas the military typically comes in waves depending on deployment and times of war. First responders are, throughout their careers, constantly exposed to trauma. Now, Dave Forbes yesterday spoke about this a bit, and he highlighted in his talk that according to meta-analyses, rates of PTSD occur in at least 10% of emergency responders. That's probably an underestimate, because collecting data in these populations is very, very hard, because they're notoriously underreporting because of fears of challenges to promotion, rights to carry arms, and other factors. So it could well be more than 10%. Now, my particular team, we started working with emergency responders a number of years ago. In my team, I run a traumatic stress clinic and have for about 20 years, and we do treatment trials of post-traumatic stress, and we have for many years, and they focus on psychological treatments, mainly cognitive behaviour therapy treatments, and we do a good job. They always turn out to be quite effective. Well, because we were getting more and more referrals, mainly from police and other emergency responders, we started a particular program where we adapted our CBT module and just gave it just to first responders. This was a number of years ago. And we actually stopped doing it after we'd seen 20 or 30 mainly police. And the reason we stopped was that it just sucked. We just were not making these people better, which really surprised us because we always had good success with our treatment approach. So we went back and looked at all the cases where we weren't doing well and tried to work out why not. And again, Dave Forbes covered a lot of this yesterday. But essentially the presentation of a lot of these patients was that they weren't presenting with simple PTSD, but it was a range of comorbidities and a range of distinctive problems that they were having that made them rather resistant to the normal trauma-focused exposure therapy. There was huge rates of alcohol abuse, lots of anger, lots of depression, lots of mistrust, and lots of ongoing stress, not so much coming from threats, as we would normally expect it, but from organisational stress. Where I work, the organisational lack of support from the employer and the organisation is often notorious. And putting all this together, it made our treatment not work. So we thought, well, we better then think about how to do it better. Now, when it's interesting and you actually look at the literature on treating emergency responders, even though police, firefighters, and paramedics are in every country around the world, and it is amongst the most highly exposed population when it comes to trauma, in the literature, we actually have no empirical evidence as to what is the best way to treat these people for PTSD. There are some very small pilot studies done, but there are none adequately done, adequately powered trials. And this is a major challenge to police and firefighter and other organisations around the world, because what policies should they be employing? A few weeks ago, I was in Vancouver. I was addressing the International Association of Firefighters. And this is a very large group that's responsible for firefighting across North America. And after cancer, their biggest concern is PTSD and associated problems. And in talking to them, they grapple with the notion of what should their policy be? What should they be arguing to governments in each of the states in the US in mandating what should be the treatment that government should be paying for to actually look after their employees? So we set about actually trying to fill this evidence gap by doing a trial. And we tried to do it differently. We took the evidence base that we have at the moment, which we know is trauma-focused, exposure-based therapy. We know that that is the best treatment we have, and so it's good to retain that. But we needed to adapt it so it was meaningful to the emergency responders. So we had to extend it to more sessions, and we had to build in other components. And the first thing we needed to do was add additional sessions simply to get the trust. And I know that is a hard thing to articulate and operationalize in a manual, but it is absolutely critical that we actually could get these men and women to actually understand the clinicians and trust the clinicians that they were working with. They needed to understand that we understood their language, their experience, and that we could somehow gel with what they had been through. And then we had to give sessions to actually teaching them certain skills to be able to manage their distinctive problems. And this was not a one-size-fits-all. It depended on the patient, which is a challenge to most manualised treatments where you just give the same thing to everybody. But our field is generally moving away from the idea that treatment manuals are cookbooks. You need to use evidence-based approaches that are tailored to the individual needs of the patient. Now, for some of these first responders, their major problem was depression. For others, it was alcohol. For others, it was interpersonal difficulties. For others, it was actually emotional tolerance. That is, they were so reactive, they had difficulty maintaining engagement in therapy because they could not contain their emotional distress. For others, it was panic attacks. So we actually taught them skills, evidence-based skills in how to deal with some of these problems before we launched into the more traditional exposure-based therapies. And we ended up, well, I should also say that one of the reasons we did this was that we also looked at, over the course of all the years that we've been seeing patients in my clinic, what really stood out for the emergency responders. And what I ended up doing in advance of this talk, actually, was I looked at about 350 patients that had attended our clinic. And about half were first responders and half were civilians. And I looked at what the different symptom presentation was. And as I think Bob Asano spoke yesterday about, in the DSM-5, we have 4 different symptom clusters. And what really stood out in terms of what distinguished the first responders from the civilians is the alterations in cognition and mood, that cluster of symptoms. In terms of self-blame, in terms of emotional numbing, detachment, withdrawal, the first responders were far more likely to report them as being the major problems than were the civilians. And this was really where most of the police were needing help before we launched into traditional therapy. So we went ahead and we did a trial. We randomized 100 first responders, they were mainly police. And we actually, it's a complicated design, we're actually asked a second question as well, because traditionally in exposure-based therapy, we give people 40 minutes of exposure to their trauma memory. There's a lot of debate about how one does that, and there's a lot of resistance by clinicians in actually implementing it. And so we actually did an alternate condition where people were randomized to getting that with the additional emergency response-oriented modules that I spoke about, or they got exposure therapy that was only 10 minutes long. So you either got 40 minutes or 10 minutes. And a third group was simply put on a wait list for 3 months before they were allocated to one of the 2 active conditions. And to cut a long story short, what we found, as we expected, at the 3-month mark was that both forms of the cognitive behaviour therapy were doing much, much better than the wait list. And then when we looked at the follow-up data 6 months later, after everybody had finished treatment, we found that both forms of the CBT, whether you got long exposure or brief exposure, they were doing equally well at 6 months follow-up. And they both were doing very well. The effect size of both conditions was large. And so that does tell us that we do have an evidence base, and that if you are going to be dealing with police, firefighters, or paramedics, this is the sort of treatment you should be employing. It's not going to work for everybody, but it is the treatment of choice. Now, that's important news because I know there's a lot of agencies around the world that are crying out for this sort of evidence. But, and I think it was as Dave Forbes said yesterday, as with all of these treatment trials, at least a third of the people do not respond very well. And we certainly found that in our treatment. And so one of the things that we did in this particular treatment study was that we were trying to find out what predicts those that are going to respond well to treatment and who's not going to respond well. And we looked at a whole bunch of factors, and let me just tell you about one. And it actually takes a neuroscience perspective. So for about half of the people who came into this trial, we actually put them in an MRI test. This is a brain imaging paradigm. And we did a number of things. This is before they got treated. And one of the things we asked them to do was to do a reappraisal paradigm. Now, what do I mean by reappraisal? Reappraisal is a term that describes one of the basic mechanisms, or one of the basic processes that we engage in cognitive behaviour therapy. What it involves is that whenever I have a very adverse experience, an adverse emotional response to something, or I interpret something in a very negative way, I need to be able to reappraise it in a way that's more adaptive, more functional, and that actually results in a better emotional experience than the one I previously had. This is the core of most psychological interventions across any kind of disorder. And it's also one of the major villains, if you like, when it's not working correctly, which is why people develop and maintain a psychological disorder, is that I'm appraising the event in a very, very maladaptive way. So what does the therapy try to do? It tries to teach people to reappraise it in a very functional, adaptive way. Now, when it comes to neuroscience, this has been studied many, many times. And normally what happens is we get a person in a brain scanner and people actually get to see things that are horrible. And they're asked to either just watch it or to reappraise it. And when the person is reappraising, we're actually looking at what's happening in brain activity. And to cut a long story short, because there's been dozens and dozens and dozens of these trials done, there's one particular brain region that's always got to be shown to be active when a person is successfully reappraising. It's a little part of the brain called the Dorsal Lateral Prefrontal Cortex. It's one of the higher cortical regions. This is a very important part of the brain when it comes to regulating other responses. And it's interesting because it's been studied in PTSD a bit. And one study in war veterans, for example, found that the war veterans, when they're in a brain scanner and they're engaging in reappraisal of negative experiences, they're deficient in being able to recruit this dorsolateral prefrontal cortex. So we gave this paradigm to all these patients who came into our treatment. And then when we've looked at those who either responded or how they responded afterwards, we found that the extent to which somebody responded to our treatment was strongly predicted by how well they were recruiting the dorsolateral prefrontal cortex before treatment. We also recruited a bunch of healthy controls. as a control group. And we divided the treatment sample into those who were responders and non-responders, and we compared them against the healthy controls. And what we found was that the way the healthy controls and the way the treatment responders able to recruit their dorsal lateral prefrontal cortex was the same. But these people actually were recruiting the DLPFC much, much stronger than the non-responders. So what does all this mean? It means that the likelihood of me being able to use this treatment actually is very much reliant on the extent to which I actually have a neural architecture that's able to be recruiting that part of the brain that I need to be able to engage in therapy that helps me understand my experiences, my symptoms, my role in the trauma differently than what I had before. But if that part of the brain is not working properly, then I'm actually less likely to respond well to treatment. Now, what does this mean when it comes to what do we do with that finding? I think it was Sandy McFarlane yesterday asked the question, with neuroscience and all the advances and all the activity that it engages in, what does it really achieve in helping us advance the goal of better treatments? Well, I think it is important because what this is telling us is how do we then tweak our treatments, or how do we tailor our treatments to people who aren't able to engage in that part of the brain or that particular strategy that we know is actually going to lead to a better outcome. And that's what's taking us now into the next stage. So for example, if I come back to our treatment trial of the first responders, I told you earlier that we actually got a very good effect in actually reducing people's PTSD. What I didn't tell you, and this surprised me a lot, was that our treatment was not that effective in reducing their depression. Now, this is unusual in the PTSD literature because in most treatment trials, you'll see that as the PTSD comes down, the trauma-focused cognitive behavior therapy, normally the depression will actually reduce with it. It's seen as like a ripple effect. We didn't see that. And this is a worry because often it's the long-term impairment that actually underpins somebody's capacity to function in society and in their life generally is more to do with their depression than with their PTSD. Because it's the social detachment, it's the lack of energy, it's the social withdrawal. These are just maintaining a person's incapacity to function. So what we're doing now is we're doing a second trial, and we're actually repeating the same intervention, but we're augmenting it by trying to actually identify specific mechanisms that we think might target what is actually going to deal with that difficulty in reappraising who I am and my experiences. And this is sort of where the main point I wanted to make this morning is that I think in terms of where the field is probably heading in terms of innovations in treatment, is we're needing to get down to the very specific mechanisms or very specific processes that we think are actually standing in the way of people getting back to their optimal way of functioning. Now, in the case of the first responder trial, when we did a post-mortem, if you like, of all the people who did not respond, and when I sit down with all my therapists and we work out why are people not responding, there's a very universal theme coming through. Now, many of these people were emergency responders that had been on the job for decades. And essentially, the people who weren't responding were ruminating repeatedly on loss of identity, their loss of capacity to function as a police officer or as a firefighter, ruminating on just the amount of negativity they see in life when you've attended hundreds and hundreds of sex crime scenes, or you've picked up so many dead children off a highway, or you've just done so many other things, seen colleagues suicide or whatever. When you've had so much of a dosage of that, it just overwhelms people with a sense of just how crappy life can be. And people tend to ruminate on this. So we're actually engaging in a different type of treatment approach where we actually train people to actually focus on other types of memories as a skill that actually focus away from that negative ruminating and focusing on appraisals of themselves, on experiences of the past where they have been successful, on other aspects of their identity that actually are very positive and gratifying. And there's actually good evidence from areas outside PTSD where this is actually very, very helpful in alleviating depression. Now, whether this works or not, I don't know. We have to see. But the point is it's focusing on trying to identify specific mechanisms that we know are deficient. And really going forward from here in terms of innovations, I think yesterday Dave Forbes mentioned this in relation to the Centenary for Anzac initiative. And this is something that we're quite excited about, because really the drive of the Centenary for Anzac Institute, what it's trying to do is, and the reason it's being funded, is to actually identify how do we actually get more people functioning better after post-traumatic stress. After those 20 or 30 years, in a sense, everyone agrees now, we've hit a bit of a brick wall. We know that, most people will get better following the treatment we've got, but we know such a significant proportion won't. Now, people have been saying this for 10, 20 years, but actually have we been able to improve our hit rate over that time? The short answer is no, we have not. We've played with all sorts of possibilities, but we really haven't made any huge gains, which is disappointing. And so really, I think, my opinion at the moment is that we need a bit of a paradigm shift. And that paradigm shift is getting away from the notion of the general diagnostic categories that we've always been talking about, like post-traumatic stress disorder, depression, alcohol abuse, or whatever. And we have these very general pigeonholed categories that are committee-driven by bodies such as DSM or ICD. But really, they're not validated by evidence at all. If you actually look at so much of the empirical evidence about biological underpinnings, cognitive underpinnings, emotional underpinnings, behavioural underpinnings, so many of these underscore all of these disorders. And we're far better off looking at the basic problems that people have, because that is actually what typically characterises the person and characterises the person's resistance to actually responding to a particular intervention. Now, we actually have very good interventions for many of the problems that people experience, but they aren't necessarily encapsulated in these big diagnostic umbrella categories. Again, I think it was yesterday Bob Asano was talking a lot about the post-traumatic stress sort of umbrella, and that really it encompasses many, many different types of problems. And I do think this is the sort of approach we need to be taking. And my expectation, my hope in the Centenary for Anzac Institute is that this is going to be the spirit upon which we are going to move forward. We're not going to take a very simplistic, gross diagnostic approach, but we're going to say, what are the specific mechanisms that we think are actually problematic? What does the evidence tell us that's problematic? And how do we then push forward with new research to help us come up with better interventions that can target that particular problem that is easily translatable into a new intervention that can actually move us into a better hit rate with people that we're trying to treat. And it may not end up with having a reduced rate of PTSD or a reduced rate of PTSD, but it may end up with something like an improved capacity for sleep. Or it may end up with fewer anger attacks, or better family functioning, or better social engagement. Now, these are actually far more nuanced, hard to measure constructs, but they are measurable, and there are ways that we can actually target them. And I think, again, just a comment about the Centenary for Anzac Institute. I think what I'm very much looking forward to in that, it is not going to be one of those institutes where we set up, from an ivory tower point of view, a research agenda that we think is actually going to be important and let's go along our merry way, which is typically how these things are done. But the way our initial discussions are going is it's very much going to be a partnership with those people who actually have far more experience and expertise in the field of veteran and military mental health. And they are very much going to be guiding exactly what are the needs, what are the stated problems that veterans currently have. And that is really what they need to be shaping in terms of what the research agenda is going to be. Now, as academics, we actually have great expertise in doing research. but it's the organisations and the agencies that deal with the veterans. They're the ones with the real expertise in what those needs are. Earlier you heard from Stuart Cameron about the RSL. Now the RSL has been doing this for a century. They have an incredible amount of expertise when it comes to actually identifying what are the specific needs of veterans when it comes to mental and social health. Well, I think, for an example, I think what the Centenary will be doing is one of the first things on our agenda. We'll be sitting down with RSL and saying, what do we need to look at? What are the main things we need to focus on? And it's not going to be something global like PTSD or depression. It's going to be specific processes. And if we can identify what those mechanisms are, then I think we'll actually have a far better opportunity to really empirically then demonstrate this is what we can measure, this is what we can research, and this is how we can then hopefully develop that into a better intervention that hopefully will make a difference, not only to veterans, not only to soldiers and other defence personnel, but emergency services and other people in the community. And I think probably that is the best approach going forward in terms of how we can actually improve post-traumatic stress generally, both in and outside the emergency service, military, veteran health domain. Now, what I've just realised is not having PowerPoints helps me talk faster than I normally do. But that is really the main points I wanted to make, and I think we're probably running a little bit behind time anyway, so I think I will stop there. Thank you.